everyone. So we just had a wonderful session about abstracts in rehabilitation at the ICS 2025. And I'm here with Victoria and Tanzeela because they both presented amazing abstract in the session. So can you just start by summarizing what is the topic of your presentation that you presented today?
Thank you. So I had two abstracts to present today. Both were involved around educating our patients to help improve the quality of care being provided to them. First one was around having group-based education sessions for our patients using rectal irrigation for problems with evacuation difficulties. And the reason why we set these sessions up was because to support our patients, particularly with the practical aspects of using irrigation, to showcase them what the different devices look like, because we do have a lot of patients who are very nervous around using these kind of products, and also to be able to meet others in similar situations so they know that they're not alone. And then they were also able to register for the products on the same day should they wish to start. So we started these sessions back in 2012, and we've had these 2 to 3 times a year, where the initial part of the session involves bowel specialist nurses talking to them about the defecatory disorders and how they're managed, and then they go around like a speed dating style into different breakout rooms where they see different types of irrigation devices available and have a little play with it essentially. Towards the end, obviously, if they want to be registered and get started on irrigation the same day, they can do that, or another time when they have the appointment. So we collected patient feedback because we wanted to know what kind of service we're providing to them by doing these sessions, and we received some really positive feedback where over 80% of the patients felt that they found the sessions very useful to attend. They found it very helpful to attend it with people having similar symptoms, and they would recommend it to family and friends. And the other abstract was kind of similar on the similar pattern, where because we get a mix of patients with symptoms of constipation and fecal incontinence. So we had these educational group sessions again for them, where we were trying to have a multidisciplinary approach so that patients do not have to attend multiple appointments. So on the day they were seeing bowel specialist nurses, physiotherapists, as well as a dietitian. We were talking about the symptoms, how to manage them, and then again towards the end there was a discussion, question and answer session, and feedback that was received was quite positive. So I think this is the way forward, because we have seen in literature that patients attending these group sessions, they are able to self-manage chronic problems, and they're found to be more compliant if they do attend such kind of sessions. So I think that's the way forward in terms of where we also have limited resources, where a lot more patients can attend these at the same time as opposed to one-to-one consultation. So yeah,
I think it is such an original and innovative topic, because we don't really know about the efficacy or effects of conservative management in these type of patients suffering from these conditions. I was wondering, when I was listening to you during your presentation, were you thinking that maybe they might be reluctant to go in group, because it's there's a lot of stigma associated with these conditions? From your data, it doesn't seem that this is what was happening, right?
So when we offered initially to the patients, obviously we did have some patients who had social anxiety, and not just to attend the session but even to commute to the hospital, because we are based in center of London, and we get referrals from urban and rural areas, so they even have to take trains to get into the hospital. So for those, it was only recently we started doing virtual sessions on Microsoft Teams, where patients felt assured that we do not have to travel, we do not have to attend it with other people, we can turn the cameras off, and our identities will not be revealed.
Okay, so they could hide it, and if they didn't feel comfortable into revealing who they were, it was okay that they don't. Okay, that's
so the study that I presented today, actually, interestingly, a third of the patients attended the sessions virtually. Not the irrigation one, because we have to showcase the products and they have to go around the rooms, but the bowel education one, they can attend, especially patients who have incontinence because they were finding it very difficult to commute as they would want to run to the toilet, for example, due to fecal urgency. So virtual sessions actually led to a lot of improvement in the attendance where they were able to attend and benefit from it. Otherwise, when they were just face to face, a lot of them couldn't make it because of the symptoms. They just couldn't travel to the hospital.
Exactly, and then it's less personal if you have the possibility of not revealing who you are.
Exactly, yeah.
And what about you, your presentation? Can you summarize this for us?
So we looked at improving the quality of life and patient experience for people living with dementia in the hospital settings. And we based our work around an ethnography study that Katie Featherstone did for the National Institute of Healthcare Research. And basically it was just looking at continence care in dementia patients. And it was pretty poor. Often they were put in pads. There was no promotion of continence. And it was really trying to open that up. And within our study, we wanted to encourage the staff's perceptives and how they can actually make a difference for these patients living with dementia. But it was really important to have them on board because I think getting that change and that sustained change was so important that they really led it. We also had co-production with patients actually forming lots of the surveys that we used in the study.
So, what were the limitations? You were assessing barriers for health professionals to implement those type of treatment.
Yeah.
Do you think that how can we solve it? Is it through training? So, from your study, what are the way forward to implement all of this?
Some of the barriers were very difficult. Lots of staff said they didn't have enough time to perform the care that they wanted. They acknowledged that continence care was important, but they didn't feel they had enough time to deliver that. In some of our dementia patients, we have enhanced level of care where they may be nursed on a ratio of 1:1 or 1:2. So there is that opportunity to provide that continence promotion and care and assessment. So that was a good thing. Some of the barriers I hinted to within the presentation is lots of our hospitals, the actual buildings themselves are very old, built in the Victorian eras. The toilet facilities are not great. So there were some barriers around actually making the toilet facilities more dementia friendly for patients. So that was a big barrier. And it's just getting staff to the education sessions as well. Although we provided face-to-face training, sort of online e-learning as well was preferable for lots, so they could access it at a convenient time for them.
Mm-hmm. And both of you, what are the way forward that you wish to? Do you wish to do more research regarding this topic, or where are you orienting your future work with after these studies that you presented?
I think in particular to these studies, I would say that the way forward is to try, because we now know that patients do benefit from these sessions as we have collected patient feedback. I think the next step would be to how can we recruit more and more patients to attend these sessions to get most out of it. So that, because one of the studies also showed that after having attended these sessions, it's also reduced their waiting time. So that is like improved quality in providing care. So I think way forward is to try and get as many as we can and actually try and ascertain the barriers for them not being able to attend these sessions. So if they are modifiable, those can be modified so patients can actually benefit from these sessions, because at the end of the day, our care is centered around the patients. So that should be the cornerstone of everything that we do. So I guess that's the way forward from...
So is there any way that you can do a randomized controlled trial proving the efficacy of these type of treatments? Sometimes it is this level of design that makes the change in policy, or is it something that is on the map for you, or...
Well, a trial at this point, I don't think it's on the cards yet. But even having said that, from a healthcare institution perspective as well, where we've got limited resources, because let's say if in a morning clinic, a typical nurse in our unit will see 3 new and 2 follow-up patients. That's 5 follow-up patients. But in a group, actually, in the morning when they come in, we've seen like between 10 and 15 patients. So from efficacy point of view as well, and using resources in a constrained environment, I think this is the way forward without patients having to wait for longer. So again, patients have actually asked us if this could be done more frequently, especially the irrigation ones, which we do only 2 or 3 times a year. But then again, there's many other more clinical commitments that with the limited capacity we have within the team, we can try, but at this point I don't think we'd be able to expand it much more unless we've got like some more resources and time as well to spare outside the other clinical commitments.
Yes.
I agree, it's so difficult. Lots of this work is done on top of the day job.
Yeah.
And a randomized control trial would be a real luxury and would be fantastic, as it is gold standard. But certainly for us, it is doing the day job on top of everything else that we're doing. And I think the quality improvement methodology that we chose to use, where we are looking at that data and having to prove that we are making changes, is a step forward. It's not a randomized control trial, but it is showing that we are making a difference.
And congratulations for your award.
Oh, thank you. That
because
was
you
quite
won a
unexpected,
public awareness award or something entitled that way. So I think it's showing the importance of your work and the novelty of it.
Absolutely, and it's very much a group effort. As I said, it's very much comes down to leadership, and whilst I am very passionate about continence care, when we are looking at the ward areas, it does come down to the ward managers and the area managers to really take this forward and lead the way for this in order for that change to occur. I can keep going on about it day after day, but it needs for them to actually take up that gauntlet really and make sure that they continue with the work.
So you definitely contributed to our good session that we had. Is there any topic that you heard in our session that was surprising for you or interesting, or what have you learned from our session today?
I think there were quite a few interesting topics today, especially because we had global representation. So we had people presenting from various parts of the world. I wouldn't say shocking. To some of them I could relate. For example, that presentation about cultural differences of how symptoms are perceived in the Middle East, and given that they have a predominant Muslim population, as a Muslim, I could relate to all those problems, and those are real challenges. So I guess the first step in that barrier comes from community-wide education that should really begin in the primary care, to make patients understand that do not consider this as a normal as part of aging, for example, or don't consider this as a taboo. It's a problem that can be fixed provided you seek care, for example. It's okay to be vocal about it to the right people. So I found that talk really interesting. Sadly, we ran out of time and we couldn't finish it. And the other one I really found interesting was the Nepalese study, because that was such important stats about patients' understanding of what symptoms of urinary incontinence would involve, and how they proceed in using the pelvic floor, to strengthening it, to use the exercises. So again, it was good to see that lots of work is being done regarding patient education, as well as education for trainees and staff, because it's an ever-evolving procedure. You're learning every day something new. So yeah, I think those are a few of the many other interesting talks.
And what about you?
I think the same, really. The cultural one, I think that was very, very interesting. And in the health board in which I work, we have a considerable Muslim population, and lots of our patients are Muslims. And I'd never really thought about it in that content. So that was really informative, and I think something that I'll pursue when I get home too. And also I loved your talk around the group sessions around waiting lists, because we are faced with an ever-increasing amount of patients on our waiting list and how we best manage them. And I think we do have to start thinking differently about these patients And if you can deliver that information in a group session, it's such valuable to impart information around, you know, the fluids, diet, all the behavioural changes that can really make a difference to them. And it's a great way to do that. So I'm very interested in taking that back to the UK as well when I return.
I think definitely we had some eye-opening presentation today, and I would like to thank you both for conducting this really important work, and I hope that you will continue with those projects that we discuss and many others, and you will come back to the ICS in the upcoming years to present the rest of your work.
Thank you for inviting us.
Thank you very much. Thank you.